Let's talk about sleep apnea in this video. So polysomnographic profiles define basic two states of sleep. One is REM sleep, that is rapid eye movement sleep, and one is non-rapid eye movement sleep. NREM sleep is further divided into three stages: N1, N2 and N3, characterized by increasing arousal threshold and slowing of the cortical EEG. REM sleep is characterized by low amplitude, mixed frequency EEG similar to that of NREM stage N1 sleep. An electrooculogram shows REM's rapid eye movements which tend to occur in flurries or in bursts. So these are the basic two categories of sleep. So coming to the organization of human sleep, after sleep onset, sleep usually progresses from NREM stages N1 to N3 sleep within 45 to 60 minutes. Stage NREM stage N3, also known as slow wave sleep, predominates in the first third of the night and comprises up to 15 to 25% of total nocturnal sleep time in young adults. The first REM episode usually occurs in the second hour of sleep. This is an important MCQ. NREM and REM sleep alternate throughout the night with an average period of 90 to 110 minutes. The ultradian sleep cycle. This is again an MCQ. Overall, in a healthy young adult, REM sleep constitutes about 20 to 25% of the total sleep, and NREM stages N1 and N2 constitute about 50 to 60%. Again, this is asked many times. Coming to the obstructive sleep apnea or OSA. Obstructive sleep apnea is characterized by episodes of complete or partial upper airway obstruction during sleep. Episodic airway obstruction is usually associated with oxyhemoglobin desaturation or arousal from sleep. So airway obstruction during sleep will guess by two things. One is desaturation, like pulse ox will show the oxygen saturation that will dip, or patient will arouse from sleep due to apnea or hypoxia. The symptoms of sleep apnea usually include chronic snoring, insomnia, gasping or breath holding, unrefreshing sleep. The patient does not feel refreshed after getting up in the morning, and very important is daytime sleepiness. So certain definitions: apnea, cessation of airflow for more than 10 seconds during sleep, accompanied by persistent respiratory effort, obstructive apnea, or absence of respiratory effort in case of central apnea. Hypopnea is a 30% reduction in airflow for at least 10 seconds during sleep that is accompanied by a either greater than 3% desaturation or an arousal. So this is the definition of hypopnea. Respiratory effort related arousal, partial obstruction that does not meet the criteria for hypopnea but provides evidence of increased respiratory effort, usually during pleural pressure monitoring, punctuated by an arousal. Flow limited breath is in partially obstructed breath, identified by a flattened or scooped out inspiratory curve. Now, how will you confirm a diagnosis of OSA? The diagnosis of OSA can be confirmed by if the apnea hypopnea index, that is the sum of per hour episodes of apnea and hypopnea, or respiratory distress index, the sum of per hour of episodes of apnea, hypopnea, and respiratory effort related arousal, that is RERAs, established by polysomnography or portable sleep test is greater than 15 episodes per hour. If apnea, hypopnea, and RERA are more than 15 episodes per hour, then you diagnose OSA. However, 5 episodes per hour is considered sufficient for diagnosis if additional symptoms or comorbidities are present. So coming to the pathophysiology, what happens is during inspiration, the intraluminal pharyngeal pressure becomes increasingly negative, creating a suctioning force. Because the pharyngeal airway does not have any bone or cartilage, airway patency is dependent on the stabilizing influence of pharyngeal dilator muscles. Though these muscles are continually activated during wakefulness, Unless neuromuscular output declines during sleep onset. In patients with a collapsible airway, the reduction in neuromuscular output results in transient episodes of pharyngeal collapse manifesting as apnea or near collapse manifesting as hypopnea. So basically, because of the upper pharyngeal airway does not have any bone or cartilage and the airway patency is not maintained due to the decreased neuromuscular output during sleep. So this is the basic pathophysiology of sleep apnea. The risk factors and prevalence. The major risk factors are obesity and male sex, mandibular retrognathia or micrognathia, a positive family history, genetic syndromes that reduce upper airway patency like Down syndrome, Treacher-Collins syndrome, adenotonsillar hypertrophy, especially in children, menopause in women, and endocrine syndromes like acromegaly and hypothyroidism. The gold standard for diagnosis is overnight polysomnogram. This is again a very important MCQ. So, obstructive sleep apnea, hypopnea syndrome, quantification and severity scale. So, you remember mild is apnea hypopnea index between 5 to 14 events, moderate is 15 to 29 events, and severe is more than 30 events per hour. Behavioral therapy management is first very important is weight loss, exercise, nasal obstruction or any allergy treatment that needs to be treated, sedative avoidance, cessation of smoking, sleep hygiene. They should sleep at a particular time, get up at a particular time, consistent sleep and wake times, avoid alcohol, heavy meals before bedtime, position on the side, and avoid caffeine, TV, or reading and doing any kind of activities on the bed. Use the bed usually for sleeping. Very important. CPAP is the standard medical therapy with the highest level of evidence of efficacy for OSA. Delivered through nasal or nasal oral mask, CPAP works with a mechanical splint to hold the airway open, thus maintaining the airway patency during sleep. An overnight CPAP titration study performed either in a laboratory or with a home audio titrating device is required to determine the optimal pressure setting that reduces the number of apneas, hypopneas during sleep, improves gas exchange, and reduces arousals. So basically, this table talks about side effects of CPAP. So that is nasal congestion, claustrophobia, difficulty in exhaling, bruised nasal bridge, and aerophagia. Nasal congestion you provide heated humidification, administer saline and steroid nasal sprays. For claustrophobia, change mask interface to nasal prongs, promote habituation, practice breathing on CPAP while awake. Difficulty in exhaling, temporarily reduce pressure, provide bi-level positive airway pressure, that is BiPAP. Bruised nasal bridge, change mask interface, provide protection. Aerophagia, you usually administer antacids. The oral appliances that are recommended for treatment of mild to moderate OSA, who prefer them to CPAP or who do not tolerate CPAP, mandibular repositioning appliances (MRAs) are less efficacious than CPAP at lowering the apnea-hypopnea index, but may be better tolerated. Oral appliances for OSAs work by advancing the mandible. They'll advance the mandible forward, thus opening the airway by repositioning the lower jaw and pulling the tongue forward. It actually basically prevents the backflow of the tongue during sleep and thereby preventing the upper airway collapse. So the upper airway surgeries include uvulopalatopharyngoplasty, tonsillectomy, lateral pharyngoplasty, transpalatal advancement pharyngoplasty, expansion sphincter pharyngoplasty, maxillomandibular advancement. Hypopharyngeal approaches include genioglossus advancement, hyoid suspension, midloid glossectomy, tongue suture suspension, epiglottoplasty, and MMA. Complications are impaired glucose metabolism, cardiovascular disease like hypertension, dysarrhythmias, MI, heart failure, depression, motor vehicle accidents, cognitive dysfunction. Coming to the obesity hypoventilation syndrome, presence of obesity, that is BMI more than 30, chronic alveolar hypoventilation with daytime hypercapnia, that is awake PCO2 more than 45 mm of Hg, and sleep-related breathing disorder in the absence of any other causes of hypoventilation should be present.